Hello students, I am Dr. Srinivas, Assistant Professor in Orthopaedics. Today I will be discussing few topics like tennis elbow, golfer's elbow, dupuytrens contracture, trigger finger, spina ventosa and carpal tunnel syndrome. Tennis elbow is also called as lateral epicondylitis. It is a familiar term. It describes a variety of symptoms around the lateral aspect of the elbow. It occurs more frequently in non-athletes, though the term tennis elbow refers to athletes who play tennis. It has a peak incidence in the early 5th decade and the gender incidence is equal. The pathology is a non-specific inflammation at the origin of the extensor muscles of the forearm at the lateral epicondyle of the humerus. The activities that require repetitive supination and pronation will give rise to tennis elbow. The activities which are such as squeezing clothes, carrying suitcase are painful in this tennis elbow disease. There is pain when grasping the objects. On examination, tenderness is present over the lateral epicondyle, which is 5 mm distal and anterior to the midpoint of the lateral condyle of the humerus. The pain is usually exacerbated by resisted wrist dorsiflexion. This is called as Cosen's test. When tennis elbow is suspected, perform this Cosen's test. Here the patient will do a wrist dorsiflexion. The clinician will resist it and the pain will be increased at the lateral epicondyle. This is Cosen's test. Another test is the Mills test. This is a passive test where the patient remains passive. Only the examiner, he palpates the lateral epicondyle and he passively flexes the wrist. There will be reproduction of the pain at the lateral epicondyle. So the test is positive. So the Mills test is positive in tennis elbow. Investigations like X-rays, they are usually negative. Sometimes calcification may be present. MRI is not generally indicated. However, when done, it demonstrates thickening of the tendon. The differential diagnosis of tennis elbow would be lateral compartment osteoarthritis of the elbow joint. Another would be the radial tunnel syndrome. Treatment. Non-operative treatment is successful in 95% of the patients. Non-operative treatment initially would be rest, ice, injections, and physiotherapy such as ultrasound and electrical stimulation. If this fails, then local steroid injections, that is injecting the steroid, long-acting steroids like dipomedrol will relieve or cure the tennis elbow in most of the patients. If these also fail and if the disease is prolonged, then operative treatment might be considered, which will be effective in 90% if the surgery is done in selected patients. Coming to golfer's elbow, it is nothing but medial epicondylitis, that is tendinitis of the medial epicondyle on the inside of the elbow. It is similar to tennis elbow. In response to a minor injuries or sometimes even without any reason, the point of origin of the flexor muscles of the forearm at the medial epicondyle becomes inflamed. This is golfer's elbow. The treatment would be the same lines as the tennis elbow. Dupuytrens contracture. This is a condition characterized by flexion deformity of the fingers due to thickening and shortening of the palmar aponeurosis. The cause is unknown. However, it is hereditary in nature. There is increased incidence of this dupuytrens contracture in patients who have cirrhosis or when there is phenytoin intake. Here, the distal interphalangeal joint is spared, that is, there is no flexion at the distal interphalangeal joint. There is flexion of the PIP joint, that is the proximal interphalangeal joint, and the MCP joint, that is the metacarpophalangeal joint. Pathoanatomy. When the palmar aponeurosis or a part of it becomes thickened and slowly contracts, this causes the fingers to go into flexion. Ring finger is the most commonly affected one. It may be limited to only the medial three fingers. Dupuytrens may be associated with thickening of the plantar fascia or the penile fascia when it is called as Peyronie's disease. Dupuytrens is usually seen in males who are aged more than 50 years. It is usually bilateral. There is flexion deformity of the fingers where only the metacarpophalangeal joint and the proximal interphalangeal joint are affected. This can be differentiated with a flexor tendon contracture. Here, the DIP joints are also flexed. Another is the tabletop test that is done to detect mild cases of Dupuytrens contracture. Here, the patient is told to keep his palm on a table. If there is flexion contracture, the entire palm does not touch the table. However, it will be lifted up. Treatment. If the disease is mild and if the patient is elderly, then no treatment might be required. Another treatment would be some physicians advocate injection of collagenase to release the contracture. However, many of them don't use this. If the MCP joint is contracted, then fasciotomy is indicated. If along with this, if the PIP joint is also involved, then not only fasciotomy, fasciectomy, that is excision of the cord, will be required. In this condition, there is chance of the digital nerve getting injured. Once the contracture is released, there can be some raw area. To treat this, some patients might require full thickness skin graft. Coming to trigger finger and trigger thumb. This results from constriction of the fibrous digital sheath so that free gliding of the flexor tendon does not occur. This is nothing but stenosing tenosynovitis leading to inability to extend the flexed digit, that is triggering, which is usually seen after 45 years of age. The patient will present with pain at the base of the finger on passively extending the finger. There can be a lump or a knot in the palm. The lump is due to a thickened area of the flexor sheath. The nodule or fusiform swelling is because of the swelling of the flexor tendon just proximal to it. This nodule can be palpated with the examiner's finger and it will move with the tendon because it is a swelling of the tendon. The swollen tendon cannot enter the sheath on extending the finger from the flexed position. This is called locking of finger. This locking can be overcome by a strong extension with a snap-like trigger of a pistol. That is why it is called as trigger finger. Treatment. Usually it is non-operative in an uncomplicated patient and who has presented in a short time after the onset of symptoms. Non-operative treatments include stretching, night splinting, heat and ice therapy and ultrasonic physiotherapy. When these fail, local steroid injection will be effective even after a single injection. If this fails, then surgical release of the sheath. This will reliably relieve the problem in most of the patients. Coming to spina ventosa. This is nothing but tuberculosis of the phalangeal bones of the hand. The affected phalanx swells up like a balloon. The X-ray shows a lytic lesion distending the phalanx with presence of lot of new bone formation. This new bone formation is typical of infections. If the lytic lesion was because of a tumor, then this new bone formation will not be seen. Treatment would be curettage of the lesion and sending the specimen for histopathological examination and confirming the tuberculosis and treating with anti-tubercular drugs. Next topic is carpal tunnel syndrome. It is nothing but compression neuropathy of the median nerve at the wrist. This is the most common peripheral neuropathy. In this figure, you can see that median nerve is passing under the transverse carpal ligament, that is the carpal tunnel. Here also you can see the median nerve passing through the carpal tunnel along with the other tendons. What are the boundaries of the carpal tunnel? Volarly, we find the transverse carpal ligament. Dorsally, we have the carpal bones and the interosseous ligaments. Laterally, there is scaphoid tuberosity and the trapezium. Medially, there is pisiform and hook of Hammett. What are the contents of the carpal tunnel? It contains 9 tendons and median nerve. The tendons are tendon of flexor pollicis longus, the 4 tendons of flexor digitorum profundus and 4 tendons of flexor digitorum superficialis. Epidemiology. Carpal tunnel syndrome usually affects the middle-aged individuals and it is 3 times more common in females. Causes. Usually it is idiopathic in etiology. Rheumatoid arthritis is an inflammatory disease which can give rise to carpal tunnel syndrome. Osteoarthritis can also give rise to carpal tunnel syndrome. Post-traumatic causes, that is trauma, and after a fracture there can be the callus formation or the malunion can compress the median nerve. Endocrine causes are myxedema and acromegaly, where there is edema and overstuffing of the carpal tunnel. Symptoms are patient presents with pain, numbness, tingling which is more prominent during sleep. These symptoms or discomfort will be seen only in the radial 3.5 fingers, including the thumb. You can note that there is numbness and pain in the radial 3.5 fingers. Median nerve compression at the wrist giving rise to numbness or pain in the radial 3.5 fingers. Coming to the signs. Phalanx maneuver, Tinel sign, Durkan's compression test, weak thumb abduction, sensory testing with 2-point discrimination and pen test. This is phalanx test or the phalanx maneuver, where the wrist is flexed and kept in this position for about 1 minute, and because of compression of the median nerve, patient will develop pain and numbness in the radial 3.5 fingers. This is the Tinel sign, which is nothing but compression of the median nerve from the distal to the proximal. So at the site of the nerve compression, the patient will develop pain and numbness and tingling sensation. This is Tinel sign is positive. This is Durkan's compression test, where the median nerve is compressed at the carpal tunnel region. And if the disease is in the carpal tunnel region, there will be pain and tingling and numbness in the radial 3½ fingers. The differential diagnosis of this would be tendinitis, tenosynovitis, diabetic neuropathy and Kienbock's disease. Treatment. General treatment. Patient will be advised not to use vibratory tools, and patient should avoid repetitive wrist and hand movements and identify the cause and treat the cause. Wrist splints will also help in treating this carpal tunnel syndrome. They will be most effective when it is applied within 3 months of the onset of the symptoms. Some oral medications that can relieve the carpal tunnel symptoms would be anti-inflammatory drugs, gabapentin and pregabalin. These help in reducing the neuropathic pain. These are effective for short periods in relieving the symptoms. If these fail, then local steroid injection, that is cortisone injection, in the carpal tunnel will help in relieving symptoms in many patients. When these two fails, the option would be surgery. The name of the surgery is open carpal tunnel syndrome. Open carpal tunnel release. Here the surgeon makes a 2-inch incision in the lower palm and the wrist area. Then the carpal ligament is incised. This frees the compression of the median nerve. The release of the transverse carpal ligament increases the carpal tunnel volume by 24%. This is the incision made for releasing the carpal tunnel. This is the line of the incision, and after incision, self-retaining retractor is used, transverse carpal ligament is incised, and the median nerve can be seen. It has been decompressed. Another surgery is the endoscopic carpal tunnel release. Here, only a half-inch incision is made on the palm and a fiber optic camera is passed to see the inside of the carpal tunnel. Then another incision is made to pass the surgical tools. With these instruments, the carpal tunnel is incised and released, and thus freeing the median nerve. Thank you all for your attention.